Niacin's role in cardiovascular health has traditionally been framed within its ability to improve lipid profiles, lowering LDL and triglycerides while raising HDL cholesterol. However, emerging evidence underscores a more profound therapeutic dimension. Niacin appears to directly stabilize atherosclerotic plaques through mechanisms that are independent of its systemic lipid effects. By modulating inflammation, enhancing cholesterol trafficking, and preventing cell death within vascular lesions, niacin contributes to the formation of plaques that are less vulnerable to rupture, a critical factor in preventing myocardial infarction and stroke. At the cellular level, atherosclerotic plaques form when macrophages engulf oxidized LDL and become foam cells. These cells often accumulate unesterified, free cholesterol within their lysosomes, leading to cholesterol crystal formation. These crystals damage lysosomal membranes, triggering the release of cathepsins and activating the NLRP3 inflammasome pathway, a potent driver of interleukin-1 set, IL-1 set, secretion and local inflammation. This pro-inflammatory environment contributes to plaque instability by weakening the fibrous cap and promoting the formation of a necrotic core. Niacin directly disrupts this pathological sequence. It enhances the expression of CD38, which increases synthesis of nicotinic acid adenine dinucleotide phosphate, NAP, a signaling molecule that mobilizes calcium from lysosomes via TRPML1 channels. This calcium release activates transcriptional programs involving liver X receptor alpha, LXRA, upregulating key cholesterol transporters like NPC1, ABCA1, and ABCG1. These transporters facilitate the efflux of free cholesterol from the lysosome, preventing the accumulation that fuels inflammasome activation. The downstream result is a notable suppression of IL-1 set production, both at the gene expression level in vascular tissues and in actual secretion by macrophages. In vivo and in vitro studies confirm that niacin-treated macrophages show significantly lower inflammatory cytokine release, and this effect is abolished when CD38, LXRA, or NPC1 are silenced. Thus, the anti-inflammatory action of niacin is tightly linked to its ability to restore cholesterol trafficking and maintain lysosomal integrity. In addition to quelling inflammation, niacin reduces macrophage apoptosis, a key contributor to plaque vulnerability. In advanced atherosclerotic lesions, cell death exacerbates necrotic core formation, weakens the structural integrity of the plaque, and increases the likelihood of rupture. Niacin protects against this process by limiting lysosomal stress, reducing the cytoplasmic burden of toxic cholesterol, and preserving mitochondrial and cellular function. As a result, plaques in niacin-treated animals are characterized by a lower necrotic area, fewer apoptotic cells, and a thicker fibrous cap, all hallmarks of greater stability. Perhaps most impressively, these benefits occur without changes in total plasma cholesterol levels. This strongly suggests that niacin's vascular protective effects stem not from altering what circulates in the blood, but from transforming how cholesterol is processed and cleared within arterial wall cells. It redefines niacin as a cellular modulator of atherogenesis, not just a systemic lipid drug. This paradigm-shifting role of niacin holds particular relevance in clinical settings where residual cardiovascular risk persists despite optimal lipid control. For patients with inflammatory or plaque-unstable phenotypes, niacin may offer additional protection by mitigating the cellular stress and cytokine release that drive acute cardiovascular events. By stabilizing plaques at the cellular level, through enhanced cholesterol export, reduced inflammasome activation, and protection against apoptosis, niacin helps convert vulnerable lesions into more quiescent, stable structures. In summary, niacin contributes to plaque stability through a constellation of intracellular effects. By reducing lysosomal cholesterol buildup, suppressing inflammation, and preventing macrophage death, it fortifies plaques against rupture without relying on systemic lipid changes. This positions niacin not as an outdated therapy, but as a versatile agent that targets the cellular roots of cardiovascular events, offering a promising complement to lipid-lowering drugs in the effort to reduce atherosclerotic disease progression and its life-threatening complications.